Executive Director of the Health Policy Commission, convening today's meeting. It's so great to have everyone here today, this afternoon. Happy May, and welcome to the second Advisory Council meeting of the year. I really hope you're all well. It's truly a gorgeous day, so enjoy the sunshine if you can. So welcome to our Advisory Council members. It's great to see so many familiar faces. Would also especially like to welcome, I think I saw his face, our Commissioner, Ron Mastrogiovanni, who is joining us today. And of course, welcome to the public and our other stakeholders who are watching this meeting live on our YouTube channel. Welcome all. And thank you all for your continued engagement with the HPC. So a lot has happened since our February meeting. The state and our healthcare providers, you all have ramped up the vaccination rollout. We're now at 43.5% of the total population in our state fully vaccinated. In addition, as you all know, no new COVID deaths were reported in Massachusetts yesterday, the first time in nearly a year, which is just truly something to be grateful for. So, but we still have a ways to go. This is just great news. And I hope that you and all your families have been able to get vaccinated or are well on your way to getting vaccinated. So we have a few updates from the HPC at the top, and then I'll turn it over to David Seltz for our discussion portion. As always, we look forward to the information and guidance and counsel that you all provide, as well as the discussion with and amongst each other. So the bulk of today's meeting will be reserved for your conversation and your thoughts and your input. And throughout the meeting, as always, if you have a question, please raise your hand or send me a message in the chat. I maintain the queue throughout the meeting. It can get very long, but you will absolutely be called on as we progress. So turning to our first slide today, Ellie, listed on this slide is the whole Advisory Council, and our new members for this term are highlighted here. I introduced almost all of you at the last meeting, but I did want to take a minute to recognize two new members who we have today who weren't at our first meeting. It would be great, and I'll tell you who you are in a second, for you to introduce yourself in your organization. First, would like to welcome to our first meeting, Dr. Claire Cecile Pierre, who's the CMO of Harbor Health Services and the ED of the Kerry Murphy Healy Center for Global Health Entrepreneurship at Babson College. And then the second is Ellen Lapointe, who's the CEO of Fenway Health. Both were unable to attend our first meeting in February, so thrilled to have you join us. And I'm wondering, Dr. Pierre, if you could just introduce yourself and your organization. We'd love to just hear a little bit more about you.
Sure. Thank you so much for having me. It's a pleasure to be here with this group. I think the work you do is incredible and quite meaningful. I am a physician by training who now serves as the Chief Medical Officer of Harbor Health. Harbor Health is a network of community health centers. We have 7 locations from Boston to the Cape and 2 different delivery models of care, both fee-for-service community health and capitated PACE program for elders. I also serve as the executive director of the Kerry Murphy Healy Center for Global Entrepreneurship at Babson College. There, I focus on how our mindset really influences the way we disrupt and develop healthcare. And so I think the two have been quite a wonderful place for me to be in order to really look at what and how we address health equities in Massachusetts and beyond.
Great, thank you so much and welcome, Dr. Pierre. All right, and then Ellen, if you could just introduce yourself.
Sure, hi. Hi, everybody. It's great to be here. I'm grateful to be part of this group. I'm Ellen Lapointe. I have been the CEO of Fenway Health for just over a year. I actually started here on March 9th. So I have a book to write when this is all said and done about what it was like to jump into this role at that time. Fenway Health is a 50-year-old LGBTQIA centered federally qualified health center that's Boston based, but serves patients in the broader region and increasingly nationally with our telehealth programming. We also have a research institute that does biomedical research, population health research to really advance the field around what we know around LGBTQIA care and health. And we engage in policy advocacy work, education and training of providers, and we have an array of public health programs focused on HIV positive people and others. So I am not a clinician. I come from a health policy background primarily. That's sort of my thing. And I was most recently working in the philanthropy in the philanthropy space. So I've just come from California to do this, but this is home for me. I grew up in Maine, and I'm really glad to be back here in New England.
Thank you so much. Welcome to you both. Also, just want to mention a few changes to the council, just that I want to acknowledge here. Welcoming to his first advisory council meeting, technically in his new position, someone who we all know very well, Michael Curry, who's the president and CEO of the Mass League of Community Health Centers. Welcome to Michael. And then Jeff Gallo, who's the director of state government affairs at AstraZeneca. His seat was formerly held by Rich Buckley, who's been with us for many, many years. Rich is actually leaving AstraZeneca and has left their seat in the hands, the great hands of Jeff. So welcome, Jeff. And then we also have Zach Stanley, who's the executive vice president at MassBio, whose seat was formerly held by Bob Coughlin, who left MassBio last year. So welcome to you three as well. And let's get right into the agenda here. Ellie, if you could just push to the next slide. As I said, busy spring at the HPC, busy one for you all as well. Since the last advisory council meeting, we did host the annual hearing on the healthcare cost growth benchmark, which I talked about at our meeting in February, alongside the legislature's Joint Committee on Healthcare Financing. The annual hearing informs the decision on whether to modify the cost growth benchmark up to 3.6% or to keep it at the default rate of 3.1%. This is just an incredibly important responsibility of the HPC. It's really our central pillar for our mission to advance transparency and accountability in the healthcare system. So with respect to cost growth, on average, Massachusetts has actually controlled spending below the 3.1% target on average over the past 7 years since we've employed the benchmark as a mechanism, and that's the good news. However, we know now, CHIA has now reported that we did exceed the benchmark for 2018 to 2019, so pre-pandemic, and we did grow at 4.3% above benchmark. So at the hearing, we received testimony from a number of organizations, a wide variety of organizations, I think it was 15 total. A majority did testify in support of 3.1% as the benchmarks with a lower threshold. And thanks to many of your organizations who did provide testimony. And I just want to really quickly recap the hearing for you all and just draw a few thematic threads to frame the discussion today. As shown on this slide, what we heard is that inpatient and outpatient spending, pharmaceutical costs, and the delivery of care in high cost settings were identified as continued key drivers of spending for us all to watch, for the HPC to watch. Our community hospitals expressed support for applying a health equity lens to the benchmark, so that would take into account longstanding price variation and inadequate reimbursement levels for our community hospitals. And then finally, our employers and consumers. Employers emphasized the need to address significant affordability challenges, and consumers testified about issues of deferred care and racial disparities that they've experienced. So on the next slide, at the April 14th meeting of the HPC's Board of Commissioners, thank you, Commissioner Master Giovanni, the board did vote to set the benchmark for growth between calendar year 2021 and calendar year 2022 at 3.1%. And so this is consistent with the past 4 years of being at 3.1%. This is the last year of this middle period of having some limited authority to modify between 3.1 and 3.6%. And then next year, when the HPC sets the benchmark for calendar year 2023, we'll have a much broader authority to set the benchmark, subject to a process of legislative review, but it's a much wider range. And if there aren't any questions, I'll just move right along to my last slide. As always, please feel free to address any of these topics later in the meeting, as you all always do. Just a quick highlight, last month we just released a number of publications that I wanted to publicize. The major one being today's discussion of the COVID-19 impact study. That'll be the major agenda item for today. But we also published 2 program briefs last month. The first on the Targeted Cost Challenge Investment Program, we call this TCCI. It supports initiatives with innovative care delivery and payment models to reduce the cost of care and improve quality. And then the second brief was on the Neonatal Abstinence Syndrome Investment Program, or NAS, which supports initiatives designed to improve care for infants with NAS and for women in treatment for opioid use disorder, both during and after pregnancy. We also released our Office of Patient Protection's annual report, if anyone wants to check that out. And then in January, we released a sustainability guide based on experiences from our healthcare Innovation Investment Program awardees, which include both TCCI and NAS awardees that successfully sustain their programs beyond the HPC funded period. So these are really important learnings. And all of these publications are found on our website, mass.gov/HPC. And then on the other side of the slide, coming up this summer, we just have a lot slated for release. Just a few that I want to highlight that may be of interest to this group. The next installment of our HPC Data Points, our blog series, is going to identify trends in avoidable dental emergency department use in Massachusetts. So that's really important. And then we'll release the always highly anticipated 2020 annual healthcare cost trends report, which includes our annual set of policy recommendations. And finally, I just want to mention a new policy brief on the HPC's performance improvement plan process. And as you know, this is a process that's required by law to consider whether factors that led to increased costs of a particular healthcare entity were reasonably unanticipated or outside of the control of that entity. So that's going to be coming up as well. So again, any questions, and I will stop talking, please let me know. And while I look at the chat, I do have the pleasure of handing over the baton to my colleague, Kelly Hall, who runs the transformation and innovation side of the agency, to introduce a brand new investment program. Kelly, over to you.
Thank you so much, Colleen, and welcome everybody. I'm really pleased to be here today, and I'd like to share some important information about an upcoming investment program aimed at addressing inequities in maternal health outcomes, the BESIDE program. BESIDE stands for Birth Equity and Support through the Inclusion of Doula Expertise. And as is probably obvious from the name, its goal is to improve the care and patient experience of Black birthing people by increasing access to and use of doula services. Through this really exciting program, we hope to do a number of things, namely, increase the number of Black birthing people who are informed about the benefits of doula care and offered the opportunity to work with doulas, particularly doulas who come from the communities and share the experiences of those people. We also hope to improve prenatal, labor, and delivery and postpartum care of Black birthing people through doula support, and all the while support development of a culture of understanding and mutual respect within healthcare delivery organizations, in this case, Massachusetts, birthing hospitals and birth centers. And finally, as in the case of all of our work now, we are working very, very hard to apply an equity lens. In this case, we're working specifically to embed principles of racial equity and cultural humility in the design and the implementation of the programs. Next slide, please. So just to give you an idea of some of the program specific features, this is a $500,000 investment program with funding pursuant to Section 88, Chapter 41 of the Acts of 2019. We are hoping to make 2 awards for this program. It is open to either birthing hospitals or birth centers. And essentially this will fund a 2-year program, 3 months of which are a planning period followed by 21 months of implementation. So in terms of timing, next slide, please. We're giving you a bit of a sneak preview. The next formal step in our process is to bring the request for proposal for the BESIDE program to our board, and presuming that they approve it, we hope to issue the RFP publicly by about May 20th. During the subsequent months, we will obviously solicit input and track questions, release frequently asked questions. The goal is to undertake our review and selection process through the summer and make awards in mid-September. So I'm here today with a little bit of an ask of all of you. I know many folks in this room care deeply about maternal health and equities, have particular expertise. Please feel free to share this information with individuals and organizations who might be interested. We love to use this group as a way to sort of amplify our voices across the Commonwealth. So please do not hesitate. As soon as the RFP is approved, we'll be posting information to the HPC website, including a link to the state procurement site so that people can gain access to the RFP. And so really, if you go to our website, you will get everything you need. And as long as I'm here, I'm actually going to make a second ask. So I apologize for that. But along the same lines, as I said, we know many in this group have a deep interest in this topic. So if you have comments, suggestions, ideas, or just want to share your good advice for how to make this program a success, please do reach out. We'd be happy to hear from you. There's a link right here to the beside email address. So if you have advice to offer, we are very, very interested in hearing it. So thanks very much.
Thank you, Kelly. So yes, please spread the word on this. As Kelly said, this is really a new area for the HPC's investment programs. This entire program is really just designed to be health equity centric, embedding principles of racial equity and cultural humility in the design and in the implementation of the programs offering doula services. So we're really, really excited about this and look forward to hearing from you all about it and selecting awards this summer and kicking it off in the fall. So thank you so much, Kelly. Okay, David Seltz, we'll now turn the agenda over to you to discuss all things COVID impact study. Thank you, David.
Great. Thank you, Colleen. Thank you, everyone, for being here today. As Colleen said, wanted to spend the bulk of our time here today reflecting on the COVID impact study and really to get your reactions and thoughts to the first batch of results that we were able to release last month, and then to spend some more time talking about where we go next with this report series, and specifically wanted to spend some time talking about the impact of COVID-19 on the healthcare workforce. So we'll have some discussion questions specific to the workforce issues a little bit later on. But first, wanted to share a selection of key findings from the report, the interim report, and to get your reactions, questions, feedback, policy ideas along the way. So please feel free to interrupt on any slide, raise your hand. Colleen and I will be sure to get to you. So hope this is an engaging conversation. First, on this slide here, we can see that this was the mandate that the legislature gave us in developing this COVID-19 impact study report. And it is quite an ambitious and comprehensive mandate, and charged us with issuing an interim report by April and a final report by next January. And the mandate asks the Health Policy Commission to examine the effects of COVID-19 on the healthcare delivery system, including on access, quality, cost, and financial performance of all healthcare entities. And not only to examine and understand what those impacts are, but to make policy recommendations about what is the future state of healthcare and how can we learn from both the negative and positive impacts of COVID-19 to create a more resilient and equitable healthcare system in the future. You can see in these blue boxes here that the legislation has a number of mandates for us beyond just understanding the impact on access, cost, and quality. It asks us to develop an examination of all the inventory of healthcare services in the Commonwealth. It asks the Health Policy Commission to develop its position on what are the essential components of a robust healthcare system. It requires that we examine the impact of closures of essential services throughout the pandemic. It asks us to do a specific analysis of healthcare disparities in the Commonwealth. And then finally here, highlighted in the orange box, impact on the healthcare workforce. And as I mentioned, that's a topic that we really want to hear from you all today, later in the presentation. So for the interim report, as you can see on the next slide, this is the outline of what we were able to include in this first interim report. And I would acknowledge at the top that one, a lot of this interim report is focused on utilization and market impacts in calendar year 2020. And this is really a result of the fact that there are significant data lags for all types of healthcare data. And so many of the results that we're able to show here today are limited to that calendar year 2020, sometimes the whole year, sometimes not even the full year. So we'll acknowledge right at the top that this is really a snapshot of that time period. And many of the results do not include an examination of what the second surge or the January surge would be on the healthcare system. I think a second caveat that I want to acknowledge right away is that we had really more robust data on hospital services and hospital care. And as you'll see, most of the exhibits here today are focused on hospital care. That's really a result of the fact that this is our most robust and up-to-date data set. Thank you to our Massachusetts hospitals for their incredible commitment to reporting throughout this time period to allow the state to be able to have these types of insights. But there are many other areas in healthcare and other sectors in healthcare that we are also interested in: post-acute care, home health care, primary care, behavioral health care, not in a hospital setting. And so we were really limited in our ability to examine some of those topical areas in this first interim report. But note, and please hear me when we say we're committed to really going beyond just hospital impacts in examining the impact of COVID, and really interested in your feedback along the way about what some of those other areas of top interest would be. On the market impact side, again, focused on hospital financials, as well as the insurance market financials and changes in enrollment coverage, again, through calendar year 2020. So again, this is not the full story of the pandemic. As we know, the pandemic is still ongoing and the impacts continued throughout this calendar year. And so we really do see this as a report that's a part of a series, and one that we would expect to update as we get new and better data and information along the way. But nonetheless, we do think that there are some really interesting findings in this report that we'd love to share with you today for some conversation. So with that, I think we can move right into some of those selected findings. And I will start with utilization trends. And so here we have a number of slides that look at hospital utilization trends in calendar year 2020. The first couple of slides here are focused on the emergency department. And these slides, just to note, the emergency department slides go only through September of 2020. What this slide is showing is just the overall rate total ED visits over 2019 and 2020. And as you can see, perhaps not surprisingly, a very significant decrease in emergency department visits in April of 2020. As you can see, there were phased reopenings along the way, and some of that emergency department care volume did increase, but even by September remained almost 25% below the 2019 baseline. So even though there was a recovery of ED visits, nowhere back to kind of the pre-pandemic baseline. And I think this raises some important questions about what was the experience of care for these individuals. Was this people who did actually really need emergency care, who for one reason or another were unable to access the emergency department, or had concerns or fears about potential exposure in the emergency department? Were these patients who were able to access the care they needed, but perhaps through a different care setting, either through a telehealth or some other way? And also, we just know that as we were in kind of a complete, a lockdown situation, there was just much less travel and activity that may have resulted in less need for some emergency care. So we really wanted to try to understand a little bit more about this drop in emergency department use. And so on the next slide, what we did is we broke all those emergency department visits down by category of emergency department visit. And so here we're taking that big decrease that we saw and decomposing it into a couple of different categories. The first one, and one of the most notable, is the category of potentially avoidable emergency department visits. You can see that in the top blue line. This category had a very steep decline in April and continued to be much lower on a baseline perspective, even after the recovery throughout the summer and early fall, almost 25% lower than the 2019 baseline. We categorize potentially avoidable care as care that either is non-emergent or that does require some immediate care, but that can be likely treated in another setting besides the emergency department. This is a metric that we've tracked throughout the years as a potential indicator of inefficient care or an inefficient healthcare system, where ideally people would not have to use the emergency department, a very high cost setting of care, unless absolutely necessary. Other categories that you can see here, injury, again, had a steep decline, but a broader recovery. And then interestingly, I want to point out the dark blue line here at the bottom, which is behavioral healthcare emergency department visits, which, as you can just see from looking at the line, had the smallest decrease during the April time period. And while it is still down from a 2019 baseline, was the one category that had the smallest decline from the baseline. You can see COVID ED visits there at the very bottom of the slide. But behavioral healthcare ED visits is a really important topic that we wanted to dive into more, because we've been throughout the year, I think all of us have heard about and read about increases in behavioral healthcare boarding at our hospital. Patients who are unable to be able to get a placement and end up being stuck in the emergency department for an extended period of time. This is obviously not ideal patient care and a reflection of many different dynamics, but one that we wanted to specifically focus in on to see what the trends were for behavioral healthcare boarding during the COVID-19 period. And we, unsurprisingly, I suppose, saw that there was an increase in the proportion of patients that did result in boarding. And so we did went a little bit deeper. And on the next slide, what we can show you is that we broke that down by different age groups. And what we're showing here is the percent of behavioral healthcare visits that resulted in boarding by age group from 2019 all the way through 2020. And you can see in the yellow line at the top, perhaps most strikingly and concerningly, a significant increase in pediatric behavioral healthcare boarding. And you can see that increased throughout 2020. Not only did we see more pediatric patients resulting in boarding, we also saw that they were boarding for longer, that they were in the emergency department for a longer period of time. And this is a really interesting and concerning topic, one that so many have focused on. I would note that we do know that there was other dynamics happening at the same time period in the behavioral healthcare space, specifically for inpatient psychiatric beds. So during 2020, we do know that as a result of a couple of different dynamics, that there was a loss of almost 270 inpatient psychiatric beds, resulting from the closure of a psychiatric hospital, Trinity Hospital out in Western Massachusetts, the closure of Norwood Hospital, which experienced catastrophic flooding, and also the need to reduce some of the bed capacity within existing inpatient psychiatric hospitals in order to maintain social distancing. And so we hypothesize that this decrease in the supply of inpatient psychiatric beds is a key dynamic that may be impacting the increasing behavioral healthcare boarding that we saw during this time period. And I just want to specifically reflect on and give credit to Secretary Mary Lou Sutter's. Obviously, this has been a key priority for her for such a long time, and her office at the Executive Office of Health and Human Services recently released an important report called the Roadmap for Behavioral Healthcare Reform, which includes a number of recommendations, really important recommendations to improve our overall behavioral healthcare system, and would also acknowledge and give credit to their office's work to expand inpatient psychiatric bed capacity through a number of incentives. I'm going to pause here because I think these are important findings on behavioral healthcare and behavioral healthcare boarding, and I'd love to hear any reactions or questions or feedback from the group.
David, Colin had a question. Colin, I don't know if you want to say, if you want to read it or if you want me to read it. You're on mute.
Sorry, so I actually there was the one I raised there about ambulatory care, but actually with regard to behavioral health, obviously this is thank you for bringing this forward. It's a really concerning finding, particularly during the pandemic, where being in emergency rooms for long periods would have exposed these folks potentially to greater COVID risk. One thing I wanted to ask is whether the commission has considered proposing increased investment in peer respites, right, which would provide a critical safety valve, open up alternatives to inpatient psychiatric care that could divert folks that might be more feasible in terms of a safety point of view, because they're small, non-institutional facilities that still provide, on-site services as a way of really reducing this, because I think that this is clearly a critical problem.
Thank you, Colin, and I agree. And I think one of the great things about the behavioral healthcare roadmap that the executive office put out is it really does try to think about the entire continuum of behavioral healthcare services and care, and not just focus on the inpatient psychiatric piece, although that is one component, that there are other modalities of care that may be able to appropriately treat these patients in a non-institutional setting. So agree with that comment. Thank you, Colin.
And Amy?
Hi, everyone. Amy Rosenthal from Healthcare for All. So I really appreciate the focus on this issue. Echo the thoughts the comments that you made, David, about the roadmap and other work that's being done. Healthcare for All is part of the Children's Mental Health Campaign, and I don't know if Donna is on or not, but this is an issue that we've been talking about for a long time. I guess I just want to put the personal touch on this, because that's what we also so often try to do. Over the weekend, I got an email from a woman who's a nurse practitioner in an oncology department. So someone who's clearly well versed on how to not only use healthcare, but work the healthcare system to try to find what you need. And this person's child was on day 8 at Children's Hospital. And my understanding, I don't know if Steve or others know, but there were 60 kids boarding this weekend at Children's Hospital. So I think the hospital is trying to do everything they can to support the patients when they're there, but they're not getting, they're seeing different physicians and other clinicians. It's not the same consistency. I mean, it's when you have that many people in the ED, it's virtually impossible to provide the type of care that they need. So for me, this story over the weekend just really reminded me once again why this issue is so important. And so I think really continuing to make it something that all of us focus on is just essential. So thanks.
Thank you, Amy.
Thank you. And David Mattiotto.
Hi, thanks, David, for that. I think you hit on most of the major points. This has really been a difficult issue for the hospitals, for the EDs since really last summer. And I would say that these staffing issues have been very significant in terms of, having to have empty beds as well, which you hit on because of occasionally there being an outbreak and that impacted access. But the good news is there's help on the way. Tara Vista Hospital bought the Mercy facility and is open now. It's now called Mira Vista Hospital in Holyoke. Cambridge Hospital is going to be adding kids' beds in the coming weeks. hopefully in May this month. And also Bay State has added some child adolescent beds in the Springfield area. There were no child adolescent beds west of Worcester for quite a while. So that's good. And Children's will be having a CBAT. Mass Health has given incentives for hospitals to add beds, which has been very well received. And Mass Health, I have to say, has really stepped up in major ways that we hadn't seen before. So just wanted to get that out there. Thank you.
Thank you, David. And as you said, some expansion of capacity coming. And as you noted, in every one of those sites, pediatric beds were a part of those expansions, which is really great. One final slide here that taking a little bit of a left turn, but on the issue of behavioral health care that I wanted to share is, as I mentioned at the top, we were limited by our data availability for really examining care kind of outside of the hospital or ambulatory care, and this is a priority for us in future iterations of this work. But one thing we were able to gain through looking at DOI reporting, so this is reporting from the health plans to the Division of Insurance about what they were experiencing in terms of some utilization trends. And what we're showing here is the percent of these types of visits that both PCP visits, specialty office visits, and behavioral healthcare visits that were performed via telehealth, and that trend throughout the first 9 months of calendar year 2020. And I think most strikingly and consistent with national data, you can see the blue line of behavioral healthcare visits. All types of visits had a huge spike up in terms of the percentage that was being provided via telehealth in March and April. You can see PCP visits and specialty visits began to go down, but still at a much higher level than baseline. But really, behavioral healthcare visits maintained that very high level of telehealth use. So this is an important dynamic that we're continuing to examine. The Health Policy Commission has another responsibility and role to issue a report on telehealth in the coming years. And so we'll want to continue to think with this group and with others around how do we optimize the use of telehealth and how do we make sure that it's providing value to patients and to all patients, and thinking about some of the equity issues with telehealth and how telehealth can be best utilized for behavioral healthcare needs. And of course, we know that there were increased behavioral healthcare needs throughout this time period. So shifting gears now, and Colin, thank you for your comment around needing to address the digital divide in our communities and agree with that as a priority. So shifting gears quickly, so now we're going to be just talking briefly about hospital admissions. So before we were talking about ED visits, now we're going to be talking about hospital admissions. And here too, you can see the overall trend here for this data. We do have full calendar year data, and you can see the big drop, the recovery, and then here with the benefit of a couple extra months, you can see perhaps some impact at the end of calendar year 2020. But overall, hospital admissions were below baseline throughout calendar year 2020. But we know that the composition of that care changed dramatically during this time period. And so the first thing that we wanted to do was look at ICU days. And here we broke that down over the same time period. And you can see in the yellow line, which is ICU days, just a massive increase in the complexity of care and the critical care that was being provided by our hospitals during that spring surge. This was, of course, the time when many hospitals were converting medical surgical beds into ICU beds in order to care for these patients with, very high needs. And yet, even beyond the April and May surge, you can see throughout the calendar year that there were more ICU days than a typical baseline. So even though there were less overall admissions into our hospitals during this calendar year, the complexity of the care that our hospitals were providing was much greater. And of course, the hospitals worked together, worked with the state, and worked with our field hospitals to be able to manage these extreme care needs. So we also wanted to look at hospital admissions in the same way that we did with ED visits, by breaking that decline down by category, about what types of people were being admitted into the hospital, essentially, or kind of what was their path to being admitted into the hospital. And so we have a couple of different categories here. I'll point out a few interesting ones. First, you can see at the top, this kind of teal line is hospital admissions from the ED, where a patient presents at the ED and then is admitted to the hospital. And you can see that there was a rebounding of those admissions, but still below baseline. Moving downward through the slide, you can see the yellow line is maternity admissions. This was the least impacted category. The blue line, the light blue line, is scheduled admissions. So these are scheduled procedures or surgeries. Again, you can see a dramatic decline in April and May, and some rebounding. You can see here the COVID is in kind of that orange, which had a big spike in April, and then you can start to see the beginnings of the winter surge if you follow that line through November and December. And again, behavioral healthcare admissions were the least impacted category. On the next slide, we wanted to look at the trends in hospital admissions now by hospital cohort. And what we've done here is we've kind of bucketed together our four main hospital cohorts and tried to look at what the change in their hospital admission volume, their hospital volume, was between 2019 and 2020. And we are showing the non-COVID hospital admissions here in the blue bars. And what you can see is that across all cohorts of hospitals, all hospitals experience a decrease in kind of non-COVID hospital volume in 2020. But there is some variation across these cohorts. As you can see on the far left, the academic medical centers experienced a 13.1% drop in non-COVID hospitalizations, while right to the right, you can see our community high public payer hospitals had a larger decrease of hospital volume of 15.3%. Additionally, layered on here is, on the orange bars, is the proportion of care that was COVID. And so you can see, again, the academic medical centers, 4.5% of their volume was COVID volume in 2020, again, compared to a slightly higher number of 5.1% for our community high public payer hospitals. So I think an interesting dynamic here for the community high public payer hospitals that experienced both the biggest decrease in non-COVID volume during this year, and were serving the greatest proportion of COVID patients. And these dynamics have real financial and revenue impacts for these hospitals, which we'll speak about a little bit more when we get into talking about hospital margins. Two final slides here on hospital admissions in particular. We wanted to try to understand and focus in on COVID hospitalizations and try to understand the patient profile and the dynamics of who was being admitted for COVID during 2020. And first, we broke this down by race and ethnicity. And what we found is that Black and Hispanic patients represented a disproportionately larger amount of COVID hospitalizations. What we're showing here is in the orange bars, you can see that the share of COVID admissions for each of these categories compared to the blue bars, which is their share of all admissions. And so where the orange bars exceed the blue bars, you can see that there was a disproportionate impact on those categories. For the Black and Hispanic populations, you can see they represented double the share of their overall admissions. Conversely, for the white population shown on the far right, those bars are flips and showing that their COVID admissions were smaller percentages compared to their overall admissions during this time period. There has been a lot of great literature and work around the disproportionate impact of COVID-19 on certain racial and ethnic groups. Many of those studies look at kind of COVID cases and positivity, but this was one of the first places that we're aware of that was able to look at hospitalizations and to find this very concerning trend as well. We also then looked at this a slightly different way, which is by the community income in which the patient resides. So we broke down the state into 5 different kind of income categories, and again compared the share of COVID admissions from those areas compared to the share of all admissions. And again, where the orange bars exceed the blue bars, you can see a disproportionate impact. And there is a very striking correlation here between lower income communities being disproportionately impacted by COVID hospitalizations than higher income communities. We hope to do a lot more in future reports in examining the impact by racial and ethnic disparities, by income disparities. We think there's much more to be learned here, but wanted to share some of our first initial results. So I think that concludes the sections on kind of utilization trends. Before I move into a few slides on financial impact that we were learned, I'll pause and see if there are any reactions, questions, ideas, or concerns from what we were just able to show.
David, this is Cheryl Clark. I'm really excited to see that actual hospitalization utilization data are now available. And I'll be really curious to see going forward how we are able to keep access for diverse populations, at these levels. It sort of, I think, was a wake-up call, I'll say, I think, for many of our institutions to sort of see that people did come to seek care. And it will be important going forward to make sure that we maintain that level of access that may have been new, and that we also do what's needed within inpatient settings to make it acceptable as a part of access, and that we put things like more interpreters, et cetera, in place to protect that access. So I'm really glad to see these data, and I think it will be important for us to figure out how we can maintain this going forward.
And David, this is Deb. I'd like to echo what Cheryl just said, and having lived through this in this market at Lawrence General, and to have seen these patients firsthand, this data resonates with me very much so. And I think access and the weakened state of providers like Lawrence General because of the impact of COVID and other issues, I think access will be a significant concern, and I think it should be first and foremost, as Cheryl just mentioned, and as I'm sure many of us are worried about.
Thank you.
I also appreciate the look at avoidable ED visits and avoidable hospitalizations. I hope that we can look at them, of course, again, across race, gender, ethnicity, and socioeconomic status, but also wonder if, as a part of the study in the future, in future phases, we start looking at that space that could be managed at home or at a subacute level of care as a way that decreases costs, increases innovation, but really is efficient and designed with equitable care in mind.
Thank you, Dr. Pierre. I agree. I think there is much to be learned about, a potential opportunity to provide really high quality care that may not need to be in a hospital setting, and how can we learn from this experience. Of course, we don't want people to not get the care that they need or to avoid that care, but there is opportunities for innovation. I appreciate that comment. Dr. Dunlap?
So I appreciate your data. My concern is still that we're really modeling the rest of the world, that underserved populations are getting the vaccine last, that in fact, if we don't really reach the areas that are impacted the greatest early with vaccine and prevention strategies, that the virus will persist and will break out again in the entire community. So, we've vaccinated high-income communities at a much faster rate than we got through to the communities where we thought we'd have a problem. And I think that before we have another outbreak or a resurgence, we really have to have a strategy that works at looking at the highly impacted areas first in order to really damp this thing down faster.
Thank you, Dr. Dunlap. So shifting topics, thank you for all of those comments. Have a few more slides to share just on some of the financial and kind of market impacts, and then we'll conclude the exhibit presentation part of this and really open it up for discussion. So first, we were able to look at hospital financial information during this calendar year. And so this is the fiscal year. So it kind of goes through not the full calendar year, but really the fiscal year for hospitals. And what we're showing here is the kind of averages or the median margins by the different cohorts of different hospital types for fiscal year 2018, 2019, and 2020. And first would note that this slide does include all of the both federal and state relief that was targeted for hospitals. In 2020, you can see that all cohorts did have a positive margin, median margin, although some variability across the different cohorts. You can see in the yellow line, community hospitals on average had the lowest margins. Some had a slight increase in margins, but overall the statewide median margin did decrease during 2020. But I think it's really important to understand how much the state and federal relief funds played into this story. So on the next slide, and this is data that was reported by hospitals into CHIA. So we're now taking those same cohorts and we're showing what the median margins would be in the blue dots with the COVID relief funds, and then in the orange dots without the COVID-19 relief funds. And you can see in the bottom part of the slide that every one of these cohorts would have had a negative median margin if not for the COVID-19 relief funds. And again, with some differences in variability by cohort, with the community hospitals perhaps facing the biggest negative margin had the COVID-19 relief funds not been in place. But as always, we like to go even a level deeper on all of this because even bucketing those hospitals into cohorts masks some underlying variation where there were a number of hospitals that did have negative margins, even with the relief funds in calendar year or in fiscal year 20. So the blue bars here are showing, every bar here is a hospital in Massachusetts. The blue bars are showing what their margin was in calendar year 2020 with the relief funds, and the orange dashes indicate what it would be without the relief funds. So you can see here at the top of the slide that there were actually 17 hospitals that even with the relief funds had a negative margin in calendar year, or in fiscal year 2020. And of those 17, 13 of them were either community hospitals or community high public payer hospitals. On the bottom half of the slide, you can see that there were conversely a number of hospitals that had positive margins and would have had positive margins even without the COVID-19 relief funds. So I think it will be very important to track these financial metrics moving forward to understand the variation in financial performance across the hospitals. And as Deb mentioned earlier, not to pick on Lawrence General, but Lawrence General is on the top part of the slide as a hospital that had a negative margin even with the relief funds. And so noting that there was a preponderance of community hospitals and community high public payer hospitals in that situation has important ramifications for access to care in those communities and the financial stability of those hospitals in particular moving forward. So again, this is not the full story of the impact of COVID. This is really part one. And so it will be really important for us to continue to track these financial metrics in order to inform policy about how best to support our hospitals across the Commonwealth. I'm going to shift into insurance market changes now, but and then we'll pause and see if there are any comments on all of these. So this slide now shifting to insurance market, the top 3 insurers in Massachusetts. We're looking here at 2 metrics. One is their premium revenue, or the revenue that they're collecting from premium, and then in the orange line, what they were paying out in claims expenses. I think not surprisingly, you can see that there was a decrease in claims expenses in 2020 that certainly tracks with everything that I have presented to you thus far today, and a divergence between that premium revenue and the claims expenses, even with the premium revenue having a decline due to a number of factors, including decreased enrollment in some of our top 3 commercial health plans. I would note and caveat that this does not take into account the impact of rebates or premium credits that may be distributed later in this calendar year as a result of this divide between premium revenue and claims expenses. And then finally, 2 slides on changes in enrollment for health insurance. And first here, we're showing this by insurance type. And what you can see in the orange line at the top is a significant increase in enrollment in Mass Health. Our Medicare enrollment increased slightly in yellow, and a 3.2% decrease in commercial enrollment coverage. Again, these enrollment changes are perhaps not surprising given the economic disruption in our Commonwealth, as well as many efforts to try to maintain coverage through Mass Health wherever possible, and to maintain coverage. But nonetheless, these also have important financial impacts for both the providers and the health plans moving forward. And then finally, we looked at the commercial coverage by size of the group, kind of the employer group. And here too, we found, I think, some interesting trend. I will draw your attention to first the kind of teal line right below the black line, which shows a 1.2% drop in enrollment by what is here the large group self-insured employers. So for our large group self-insured employers, there was not a significant impact on enrollment, insurance enrollment during this time period. But as you can see in the light blue line and the gold line at the bottoms, there was a bigger decrease in enrollment for our small group employers and large group fully insured employers, which tend to be kind of medium-sized businesses. As well as then, of course, increases in non-subsidized care at the very top. So again, these are important dynamics to understand where enrollment changes are shifting and where different employer groups had varying different experiences about their ability throughout the pandemic to continue to provide coverage and afford coverage for their employees, and has I think important implications moving forward, particularly where we see this decrease in the small group employers and large group employers. Both of those are the fully insured categories. So that is all of the select findings I wanted to present today. So I'm going to pause here before we move into a further discussion on workforce in particular, and give everyone an opportunity to provide some additional comments and questions on everything we've presented so far, and where we should go next with this work. John Hurst, I saw that you had a comment in you're in the chat here, and I'm wondering if you're willing to come off mute and share that. I think it's a dynamic that others are interested in as well.
No, always, David, as you know. No, look, I understand it's complex, and I understand that there are winners and losers, but you look at the overall hospital data, and you look at everything from the emergency room drops, which, thank goodness that's happening. Let's hope we can continue that trend. But there's, with all the revenues that have gone to some of the hospitals, all the hospitals really, from the taxpayers, and with some clear winners and losers there, I just really don't understand how we're continuing to see 7% premium increases, particularly for small businesses. And you look at the drop off in the numbers on that slide, David, it just, the pain particularly is in the small group, and also a large group, 51 to 100. They're just getting more pain on their premiums than perhaps a self-insured employer is. And it's something that we've got to look at. It isn't just the size of the pie and overall pie and how it's growing, which is far too fast, far above the benchmark, but it's also how are we dividing up that pie and distributing those costs. It's something that we really have to do a deeper dive on.
Thank you, John, and agree that going beneath these numbers and seeing the variability between them is something that we're always mindful to try to accomplish.
David, this is Pat from the Home Care Alliance, and no doubt where I'm going, and others who have been on the commission with me for a while. I love that you're thinking about the post-acute system after we dig into this insurance in the hospital system. And I do think there's a story there about the stability of the post-acute system, and also a story about accessibility of post-acute care, both during the surge and even now, where we're finding, and this will come up as we talk about workforce, that in some cases demand is exceeding supply for home health services, as still people are looking to bypass nursing homes, or just in fact, as the system has ramped up with elective surgeries. So we're looking at demand exceeding supply. And I'm also thinking a lot about that spike you showed in the ICU, which was, I think, last March or April. And I think there's a really interesting story about how that spike moved through the system, out of the ICU into the post-acute system, and the financial impact of that on the stability, finances of us also seeing a sicker cohort of patients, seeing COVID patients replacing those elective surgery patients that we would have normally be seeing. And for the home health industry, the financial relief really only came in the form of payroll protection funds, and how that impacted stability and what's going to happen going forward for the home health industry. And someone mentioned, the Recovery Act, and we're seeing potentially some federal investment in home and community-based services coming out of Washington. And some of these studies about the post-acute system might help to drive how we think about investing that, what could be close to $400 million in home and community-based type service investments from Congress coming this year. So I'll leave it at that.
Thank you, Pat. And I think I'll maybe repeat something I said at the last advisory council meeting. I personally have just had such a greater appreciation of the interconnectedness of our entire healthcare continuum, and thinking about patients being treated in critical care, moving towards long-term rehab, or other types of post-acute care hospitals, back to nursing homes, back to home, and the ripple effects of the pandemic on every part of that. And so I think expose some fault lines and some areas where we didn't have the right capacity. And we really, required a tremendous amount of work to try to provide that great level of care for patients. But as you said, an opportunity to think about investments for the future. So we have a system that really can provide that high level of care throughout a patient's kind of care need or treatment time period. Dr. Dunlap?
Hi, David. I was concerned, thank you for that presentation. I was concerned about recovery for all hospitals in this, but given that the hospitals that provide care for in safety net or public domain getting hurt more, I think that the access to care, delivery, and the cost may be adversely affected because of the fact that many people are going to be diagnosed with cancer or some other malady that basically occurred while this was going on. And if they have, poor access coming forward, we're really going to have a delay and a large cost coming down the road. So I think we have to look at how we will support those institutions to get them to catch up overall, but specifically those institutions.
I agree. Thank you, Dr. Dunlap. I don't know, Deb Wilson, if you have some thoughts to add on that.
Well, first of all, thank you, Dr. Dunlap. And, I wish that I could ignore the chart and pretend it wasn't real, but Lawrence General was weak before the pandemic, and we are extremely weak after the pandemic. We have not received $1 of COVID support since last July. So we've gone through this year with an extreme reduction in volume, given, the second surge of COVID. And we are fighting to preserve services to a community of color, a community that needs us, and it's very serious. And so I really do think the focus on hospitals that are serving a community like ours, we need to make sure that we are here for the future. And obviously, this is very real. I think your charts are great, the data is great, but being here, this is a very real and serious issue that the community is going to face.
Thank you, Deb. I'm going to want to shift gears now to begin a conversation on workforce impacts. But before I do, since so much of the previous findings were on hospital findings and insurer findings, I don't know if Steve Walsh or Laura Pellegrini, if you've had any additional thoughts or reactions to the presentation.
I would just say, David, thank you. I think we always find the Health Policy Commission's data so important. For us, I think, and for the hospitals, we're still in the pandemic, although things were looking brighter. And as for premiums, I think you could always have the DOI come and speak to this group, but premiums are set prospectively, and so reflect what is coming down the pike relative to healthcare cost and what we anticipate for utilization. So to John's point, but thank you for sharing. And I think for our disproportionate share hospitals, I think we really look to work with them. I think there have been certain solutions offered in the budget and by the administration around Medicaid rates, and that seems to be where we need to be focused. I think for our hospitals that serve a large mass health population, and so we're very willing to work with those hospitals on those solutions.
Thanks, David, and thanks, Laura. And I think Laura and I are having some very productive conversations about next steps and where we can go together in the commercial market. But I'll just circle back. I think the work of the HPC, not just with this report, but really over the last 15 months, has been extraordinary. And oftentimes there isn't a feedback mechanism for us at the commission level. And I will say I just want to point out, because you didn't talk necessarily prices today, but I was a little troubled by a comment by your chairman at the last commissioners meeting. And the quote was, what's happened is that providers are making up for the reduced utilization by jacking up prices. And I have to assume that was a reaction in real time that he offered with little care or thought. But the microphone of the HPC, as you all know, is a really powerful one. And that thought has been repeated now multiple times by multiple outlets. And as the chair certainly knows, he knows this industry far better than I ever will. Prices are part of a negotiation. They don't change unilaterally. The prices that were being referred to are national in nature. And additionally, the number of deferred tests and appointments that is also within this report creates a strong likelihood that when patients actually return for care, they're unfortunately much sicker, and that means much more expensive. And so for the next year, we're going to have to be okay with that if we're going to stabilize the health of our patients and the health of our communities. We should also anticipate more challenges ahead, as Deb mentioned, and I know Chris Schuster is in the call, and Emerson has not been without their challenges. They were one of those in the top box as a community hospital. They are all weaker than when the pandemic began, and even SHIA's numbers that offer a snapshot of our health right now show that if you take away the hundreds of millions of dollars in federal relief there would be substantial losses. And it's a really bleak and devastating picture. And that was only one-time money that is slated to last through the remainder of the year. So I won't be naive enough to believe that a celebration of our health system and its heroic 100-year effort will continue much longer, but I certainly didn't anticipate that the collaboration between the HPC, your commissioners, and our providers would have moved so quickly to the other extreme at your last meeting.
Well, thank you, Steve, for the comments and the feedback. And of course, our mission is around cost containment and affordability. And so we are trying to balance all of these dynamics and in thinking about the future of our healthcare system that provides that high quality care, but at a price that people can afford as well. Thank you all for all of those comments. I want to spend, we could have spent the entire hour and a half talking about workforce impact. So I hope that we can just spend a few minutes talking about some of these questions that will be part of our continued study of the impact of COVID-19. And the statute specifically calls on us to report on the impact on the healthcare workforce. And so to begin that conversation here today, we've put a lot of questions on this slide for you, but just to summarize the ones at the top here, how did the pandemic affect the healthcare workforce and the role of healthcare workers in meeting the needs of Massachusetts patients and communities? Kind of thinking retrospectively, but also then on the right-hand side, thinking to the future. How should the healthcare system and the healthcare workforce transform to best meet patient needs now and in the future? And there are a number of kind of sub-questions to each one of these. So I'm hopeful that in our remaining few minutes today that people would be willing to offer some initial reflections or thoughts about how, one, are these the right questions to ask? Two, how we might begin to start to answer some of these questions, and three, to just really open it up and allow people to share either their own experience or their organization's experience and the intersection between COVID-19 and the healthcare workforce. I know David Mattiotto earlier today mentioned the impact on the workforce for behavioral healthcare hospitals, but we'll pause here and open to kind of initial feedback, initial thoughts, with of course a call to further input as we continue this work.
David, I think we can start with Lisa.
Great.
Hi, everyone. Thank you so much. Lisa Gorgoni from Mass Home Care. And I thank you so much for including the slide and noting long-term care and home care on the slide, because I think sometimes, obviously, they're a key component of the healthcare team, just kind of in the community. So we have certainly seen, and I know Pat alluded to this in her remarks, just because the direct care workforce in home care, but also in nursing homes, I think all the frontline home care workers, as we know, are probably the lowest paid of the healthcare workforce in general. So we saw during COVID that many of them, they did leave the workforce, and they, either because of unemployment or children, the schools being closed, a lot of them are moms. So we had a huge kind of demand, issue that has continued. We're actually tracking with Elder Affairs the demand for home care services. We have over 2,000 consumers that are waiting for matching with a home care worker right now already. And that was actually February data. So we're going to do this survey every 3 months. So we're seeing people waiting, older adults waiting, who need care, who qualify for care, who just cannot get matched with the direct care worker in the home care setting. So I think we put some proposals together for the American Rescue Plan. We have some legislative initiatives to address that. There's the healthcare collaborative that is chaired by Secretary Costa. I think a lot of work in this space, but I think it's time to really take a look at those pieces and develop a real strategic approach to addressing this long-term care, direct care workforce crisis.
Thank you so much for that, Lisa. And I think you did offer in the chat to share some data with us, and we'd absolutely welcome that. So thank you for that. Okay, Tara Gregorio next.
Thank you, Colleen, and thank you, David, and everybody for the opportunity to comment. And I would first say, yes, I think your two questions are fantastic. Just building off of what Lisa said, we are in post-acute care, at least nursing facilities, 45,000 caregivers, 90% are women, 2/3 are people of color, and 40% of are immigrants, and most don't yet earn a living wage. So we can talk about the heroic acts of our frontline staff during the pandemic. They were tested, submitted to COVID testing every single week, don and doff more PPE probably than what is worn in the ICUs, still are donning and doffing full PPE. They served as surrogate family members, since most of our residents don't in fact have family members who are visiting them prior to the pandemic, during the pandemic, and today. They adjusted to very changing, conflicting government guidance coming from our local public health departments, DPH, CDC, CMS. So they adapted, and they did this with grace and courage. And we were able to provide, as a result of federal and state temporary funding, a 10% increase in compensation, but that was temporary. And so probably one of my, and I've had a lot of bad days like you all have during this pandemic, but one of the hardest days for me was when our living wage legislation was put into a study during the summer. So our frontline staff have been very clear on what they needed pre-pandemic and what they need during the pandemic and post-pandemic, which is more staffing. We currently have a vacancy of 5,500 direct care staff that we need to hire, and that's with a utilization of 75% of our beds. We were at 90% pre-COVID, we are now at 75%. And 35% of facilities report denying hospital admissions because they can't staff beds. So the staffing crisis is acute, and we know that in order to come out of it, we have to address pipeline issues that, again, Lisa had mentioned health policy collaborative is looking at, but more than anything, wages, which are directly tied to government reimbursement. So David, I have a lot to say on this, but I appreciate the opportunity to share.
Thank you so much, Tara. Okay, Dr. Pierre, you're up next. Thank you.
Thank you. Completely agree with the 2 points made earlier, endorse and agree. And I would also add to this healthcare workforce discussion, maybe some room for 2 additional work professionals that we may not be including right now. One of them is the public health response teams. So where do they fall on the spectrum of healthcare workforce? And that would include all of those who contribute to the contact tracing effort, the community connections and resources for those who are affected by COVID, and potentially how to leverage that group beyond the COVID period, because in many ways they are extending the ambulatory care workforce in terms of connection and social supports in ways that we can't see now, but once removed, we will all feel. So it would be great to look at the public health workforce. What does that mean peri-pandemic, right? And then the second would be to think about the role of lay people trained in key behavioral health techniques, as well as key preventive health techniques to serve as bridge for families and care teams. We've seen a lot of that in behavioral health around the world, but not as much in the US. But that can actually extend the workforce for that transition again, if we're talking about reduction of cost, but not losing quality by having key people in the community who understand the needs and can really address them very quickly and serve as point persons to alert or increase the transitions of care.
Thank you for that, Dr. Pierre. That's really important to keep in mind. A lot of activity in the chat, per usual. I'm going to keep calling on folks who have their hands raised, but if you do want to say your comment for the record, please just let me know. Okay, Dr. Dunlap, you're up next.
So one of my concerns is the actual mental and physical health of the workforce itself. I think that during the pandemic, many times some healthcare workers tried to speak out about conditions and were constrained by their institutions. But I think that retention going forward and keeping people from retiring or leaving the workforce is going to depend heavily on how well we treat healthcare workers as we recover from this. I think that's really something that has to be addressed directly. And if we do that well, we can retain the people that we have, which I think we did bring some people out of retirement, but there are a lot more people thinking about retiring because of this stress.
Absolutely. Thank you so much. Okay, Carlene.
Thanks so much. Hi, Carlene Pavlos from the Massachusetts Public Health Association. I just want to say thank you to Dr. Pierre and reinforce her point about the public health workforce that was sort of stood up during this pandemic and how valuable some of those roles can be going forward. Of course, there is no ongoing funding for those roles. So local public health receives in the past has received actually no dedicated state resource and now has a small amount of state funding, but there really is no ongoing funding for local public health in our communities. And if we want that kind of extension into communities, particularly an equitable extension of those roles in communities, we're going to need to figure out how to support and fund that. And because Lisette Blondet is not here, I feel like it's pretty important to mention the role of community health centers community health workers as we think about the healthcare workforce and how important it is to be looking at community health workers and the roles both within community health centers and within community settings and how they extend care into community settings. And again, have the impact of creating greater equity, not just improved health outcomes, but improved equitable health outcomes. So both of those workforces, I think, are pretty important to pay attention to.
Absolutely. Thank you so much. Okay, David Mattiotto.
Hi, thank you. That great presentation. And I'm really glad that you all are going to look at the healthcare, the second part of this. How should the healthcare system and workforce best meet the needs now and in the future? To me, it's pretty clear that almost throughout the whole entire healthcare system, staffing is a huge issue. It's a huge issue in behavioral health. It was before the pandemic, but it's even worse now. And you know, people say we need more beds, we need more beds, we need more beds. Well, we got almost 400 empty beds now because of staff, mostly a lot of it because of staffing and acuity. So I really hope the Health Policy Commission is able to do a deep dive into the future needs. We're really I'm getting very nervous about who's gonna run these facilities. So hopefully we can help in any way with that. Thank you.
Thank you so much, David. All right, I'd like to call on one of our active chat participants, Kim Brooks, if you could just repeat the excellent comment that you made in the chat. Thank you.
Sure. I was just related to workforce and trying to think about, you know, how we create the most efficient system we can to improve the experience of caregivers. And we have so many caregivers, as was noted, you know, needed to support people at home and in these alternative care settings where we know people can do well with the right supports. But there are some infrastructure issues related to that don't allow us really to take full advantage and leverage the staff that we do have to reach more seniors and people out in the community.
Okay, great. Anyone else want to add to this conversation?
Colleen, it's Pat Kelleher again from the Home Care Alliance. I will call attention, folks, and maybe you could share it and give a shout out to the Mass Hospital Association had a Caring for the Caregiver Task Force that was put together before COVID and then continued to meet. It was chaired by the president of the Bay State Health System and Donna Glynn from Regis Nursing School. And there's some good work and recommendations in that report if people haven't seen it. I know it's on the Mass Hospital Health and Hospital Association website. and it's called Caring for the Caregivers, and has a lot of recommendations in there in terms of workforce wellness, workforce burnout, workforce supply. So I just call people's attention to that report.
Thank you, Pat. Thank you all for the comments, initial comments here on this important topic. I will say, as we continue the work, especially on well, the whole COVID-19 study, of course, but on this workforce issue, we really hope to engage all of you in helping us be able to put this story and report together, to be able to meet the questions that we're these very difficult questions that we're trying to answer. You know, how do we best meet patient needs now and in the future, and support our caregivers and workforce to be able to do that? And so you can expect to hear from us early and often. And as always, if you have additional thoughts, resources, data, information that you or your organizations have available, we would love to see it and to work with you on this important work. So with that, Colleen, I'll turn it over to you to close us out.
Okay, thank you so much, David. If no one else has any other comments, we'll let you have the last 3 minutes of your day back. Unfortunately, this group does not meet again until September 29th. Is the next meeting of the Advisory Council. So we look forward to working with you offline. As always, we love hearing from you. So please feel free to reach out to us on these or any other topics that we discussed today. And with that,